So guys, welcome back to the channel Pharmacology Made Easy. I hope you are all liking my videos and keep watching them, and don't forget to subscribe to the channel. So we have started with a series of lectures on bronchial asthma. Now we will discuss the third bronchodilators in asthma, and they are the anticholinergics, or also called as the anti-muscarinics. So they are the inhibitors of cholinergic system, also called as the parasympatholytic, or inhibitors or antagonists of muscarinic receptor. Then they are again further subdivided depending upon their duration of action into two groups. One is a SAMA and one is a LAMA. What is SAMA? Short acting muscarinic antagonist, and LAMA means long acting muscarinic antagonist. Remember, in a beta 2 agonist we have seen SABA and LABA. B, short acting beta 2 agonist and long acting beta 2 agonist. These are the antagonist and not agonist. In the SAMA there are further two drugs. One is the Ipratropium bromide, which is much commonly used and much popular and having duration of action 4 to 6 hours, and the another drug is the Oxytropium. Okay, while in LAMA, that is long acting muscarinic antagonist, drugs are Tiotropium bromide, which is much commonly used, having duration of action more than 24 hours. So you can see these have 24 hours duration of action as compared to 4 to 6 hours of Ipratropium. The other drugs in the LAMA, which are glycopyrronium, aclidinium and umeclidinium. These three are recently discovered: glycopyrronium, aclidinium and umeclidinium. But tiotropium bromide, this is present quite from few years and commonly used. So these drugs are given by inhalational route, either as a meter dose inhaler or sometimes as a dry powder inhaler, means through the rotainhaler. Now coming to the mechanism of action. These drugs, they cause the blockade of constrictor M3 receptors. As you know, muscarinic receptor M1, M2, M3, out of which M3 receptors are they are present in visceral smooth muscles, and they are responsible for bronchoconstriction through the acetylcholine. So these drugs, they block the acetylcholine by inhibiting this M3 receptor, and they will produce the bronchodilation. But one thing is that these M3 receptors, they are present mainly in the large central airways. Remember, beta 2 receptor, they are present mainly in the peripheral bronchioles. Okay, we know bronchi gets divided into the primary, secondary and tertiary bronchi, and then further tertiary bronchioles. So in the periphery, beta 2 receptors are more, while in central M3 receptors are quite more. So these are dilating mainly large and central airways, while beta 2 agonists are dilating mainly the peripheral bronchioles. But they are less effective than inhaled beta 2 agonist in asthma. So their efficacy is less as compared to the salbutamol or even the salmeterol type of the beta 2 agonist. That's why they are less preferred in asthma. But they become bronchodilators of choice in COPD. Now why this happens? Because though both asthma and COPD, though they are obstructive diseases, in COPD reflex vagal tone is the major component in the pathology, and because of which, as this drug, they are inhibiting the reflex vagal tone. As you know, vagus is a parasympathetic 10th nerve, so they inhibit the vagus, and that's how they can become the bronchodilators of choice in COPD. So in general, because though Ipratropium is a short acting having a duration of 4 to 6 hours, it cannot be useful in acute asthma. We want a drug which have only 2 to 5 minutes of action. That's why both the drugs, they are preferred in the chronic asthma rather than the treatment of acute attack of asthma. Coming to the adverse effect, they are very less with this drug because of quaternary ammonium structure. Okay, all these are the synthetic drugs which have a quaternary ammonium structure, because of which they become less lipid soluble, so there is a less penetrability into the CNS and other tissue. So characteristic anticholinergic side effect like dry mouth, blurring of vision, urinary retention and constipation, they are not observed with this drug, as well as less CNS side effect. Now coming to the important thing, combinations. So nowadays these drugs are increased more in the combination. First combination which is popular is Ipratropium bromide plus salbutamol. As you know, it is a short acting beta 2 agonist, and Ipratropium is also the SAMA, that is a short acting muscarinic antagonist. Both are given in the same inhaler, meter dose inhaler pump. Okay, especially in acute asthma exacerbations and in the COPD patients when there are the acute exacerbations. Though in acute attack of asthma, we are giving only salbutamol, not this combination. But in acute exacerbation in chronic patient or in a COPD, we can use this combination. Deolin inhaler is a popular brand name. Second combination is a LABA plus LAMA. Long-acting beta-2 agonist like salmeterol, formoterol, and long-acting muscarinic antagonist like tiotropium. And both are preferred in the COPD as well as in the chronic asthma. So they are the bronchodilator combination. Both are bronchodilator, different mechanism of action. So combination become additive to each other. Less requirement of both of the drug in combination and preferred in COPD and chronic asthma patient. And third combination, which is not very much popular, but they have come into the market, that is a triple inhaler. Okay, these are the double inhaler where we are using the two drugs, LABA or LAMA or Ipratropium plus salbutamol. Now we have added the third drug, and that is the ICS, that is inhalational corticosteroid. So ICS plus LABA plus LAMA, this combination will be preferred in a severe asthma patient who are not responding to the two drug combination. For example, from ICS we have budesonide, from LABA we have a formoterol, and from LAMA we have a glycopyrronium. So these three drugs can be useful in combination, and such another combinations will become popular in the coming years. Now we will discuss the next drug in the treatment of asthma, that is Omalizumab. Okay, so it is an antibody which is directed against the another antibody, that is a IgE. So it is an anti-IgE antibody. As I have told you that the last word in the MAB indicates the monoclonal antibody. Monoclonal antibody, while ZU indicates the humanized. So it is a humanized monoclonal antibody which is directed against the IgE antibody. So it will inhibit IgE and further sequence of events will be inhibited. It is given by subcutaneous route. So only drug in the asthma which is given by subcutaneous route. Now we will see the mechanism of action of Omalizumab. The first one, it will inhibit the binding of IgE to mast cells. As we know, in a body, first the antigen comes and it will bind with the IgE antibody. This antigen antibody complex will bind to mast cell with the help of receptor Fc-epsilon-R1, and then there is a degranulation of the mast cells and all these inflammatory mediators will be released. So first it will inhibit the binding of IgE to the mast cells. Okay. Second action of Omalizumab, it will inhibit activation of IgE which is already bound to mast cells. So some IgE may be already bound to the mast cells and it is about to activate the mast cells. So that is also inhibited by the Omalizumab. Well, third action of Omalizumab is down regulation of Fc-epsilon-R1 receptor. As we know, without Fc-epsilon-R1 receptor, IgE will not able to bind to the mast cells. So there is a down regulation, means decrease in number or decrease in the density of Fc-epsilon-R1 receptor with the help of Omalizumab. Now this Fc-epsilon-R1 receptor, they are present not only on the mast cells but also on the eosinophils, lymphocytes as well as other cells. So that is down regulated by Omalizumab. So, and it is said that about more than 90% of IgE should be neutralized, as well as there should be a down regulation of Fc-epsilon-R1 receptor so as to become the Omalizumab as an efficacious drug in asthma. Okay. Now coming to the uses of Omalizumab, it is indicated in severe extrinsic asthma with raised IgE level. We have seen in the treatment approach that asthma is of two types, extrinsic and intrinsic. Extrinsic further atopic and non-atopic. So only in atopic individuals who have other allergic diseases like allergic rhinitis, conjunctivitis, or who have a raised IgE level, Omalizumab is useful because it is going to target IgE. If there is no IgE in the etiology, then it is not going to be useful. So it is useful only in those asthma patients where the IgE is raised. Then it reduces the steroid requirement and beta-2 agonist requirement in those asthma patients, as well as it reduces the exacerbations. But it is not useful in non-allergic asthma or intrinsic asthma, means non-atopic type of extrinsic asthma as well as in intrinsic asthma. As there is no raised IgE level, the Omalizumab is found to be less efficacious. Okay. As well as it is less useful in acute asthma and status asthmaticus because it is not going to reverse the bronchoconstriction which has already been happen. So there we have to use the bronchodilator. So omalizumab mostly has a prophylactic role in the severe extrinsic asthma. But there is one limitation in the use of omalizumab, and that is the very high cost or very expensive. Because two things, it is not useful as a regular in acute asthma and other type of intrinsic asthma like, and high cost. So it is reserved for resistant asthma patient. Resistant asthma patients to what? They are not responding to the ICS, inhalational corticosteroid. In such a patients, we can try the omalizumab, provided there is a positive skin test. This skin test is done to confirm the diagnosis of allergic etiology and raised IgE level with frequent hospitalization. So such a type of the patient in which skin test is positive, IgE is raised, and they are having the frequent hospitalization due to their asthma, and they are not responding to the usual doses of inhalational corticosteroid. Such a patients will stand to benefit from the omalizumab. Nowadays, some antibodies against certain interleukins, which are inflammatory mediators, are in the development phase or have already come to the market. These are the three interleukins: interleukin 4, interleukin 5, and interleukin 13. Which are the antibodies against them? So dupilumab is an antibody against interleukin 4. Mepolizumab is an antibody against interleukin 5, while lebrikizumab is an antibody against the interleukin 13. So in a near future, we can see these antibodies coming in the market in a large quantity. That's all about omalizumab. Thank you guys for watching the video. Please subscribe to the channel.